Hello, everyone. My name is Laura Pace. I'm a neurogastroenterologist and NIH Birch Scholar. It's well established that when women present for even evaluation of routine clinical problems such as hypertension, they are more likely to be misdiagnosed with a psychological disorder such as anxiety or depression compared to their male counterparts. They're also less likely to undergo an appropriate clinical evaluation for their symptoms. This becomes even more complicated when women are presenting for complex systemic disorders. My clinical practice has focused on individuals at the center of this Venn diagram. The vast majority are female, the vast majority have a dysautonomia or autonomic nervous system disorder, a genetic connective tissue disorder such as one of the Ehlers-Danlos syndromes, and numerous immune-mediated disorders. These patients are often dismissed by the medical community due to the complexity of their disorder. As an example, a disorder of the autonomic nervous system or dysautonomia can easily have a patient present with a pan-positive review of systems. And this is obvious if we just take a quick glance at the innervation patterns of the peripheral components of the autonomic nervous system. The autonomic nervous system, which functions to respond to stress, both physiological and emotional stress, controls things from pupillary dilation, to salivation, to sweating, to vascular dilation, gastrointestinal function, and bladder function. And therefore, it's very easy to understand that someone with a dysautonomia could very easily have a pan-positive review of systems. However, when these patients are female, they're much more likely to be diagnosed, again, with a psychological disorder, rather than undergo an appropriate evaluation for a potential dysautonomia. POTS, or postural orthostatic tachycardia syndrome, is a common dysautonomia affecting 1 to 3 million people residing in the United States. It disproportionately affects females, with 90% of individuals diagnosed with POTS being female. 20 years ago, the average time to diagnosis was 6 years. Today, we're not doing much better because the average time to diagnosis is 5 years. 75% of individuals are misdiagnosed prior to the appropriate diagnosis. 34% of individuals actually have to propose that they may have POTS to their clinicians before they undergo an evaluation. These patients also are seeing a number of physicians prior to diagnosis and are frequently seen in the emergency department. And remember that this is a disorder that 90% of people with the diagnosis are female, and yet females are waiting on average 2 years longer than their male counterparts. This clearly demonstrates a significant gender bias within medical care for these patients. Again, this becomes even more complicated when you add on other disorders, including the rare genetic connective tissue disorders of the Ehlers-Danlos syndrome. Approximately 1 in 5,000 individuals worldwide have the hypermobile form of Ehlers-Danlos syndrome. And these individuals have a very significant varied phenotype. So this young woman has a diagnosis of hypermobile Ehlers-Danlos syndrome. She also has a dysautonomia, and she has an immune-mediated disorder. And yet she is able to function fairly well in her daily life and actually make a living as a professional contortionist. This young woman, on the other hand, also has hypermobile Ehlers-Danlos syndrome, a dysautonomia, and numerous immune-mediated disorders. But she is so severely affected that she also has intestinal failure, which requires that she receive all nutrition and hydration via IV access. She also has a gastric tube for gastric venting and a jejunostomy tube for medication administration. She is frequently hospitalized and has been unable to complete college due to her illness. Her brother, on the other hand, also has hypermobile Ehlers-Danlos syndrome, but he is not as severely affected. He has been able to continue to go to school and function with a fairly normal quality of life. Many of the arguments that I hear in regards to this patient is that she must be doing this to herself because her brother does not have such a severe disease. And this is not true. We actually know that there is a biological sex-dependent phenotype in these patients. And the vast majority of individuals with a very severe phenotype are female. The vast majority of individuals with an Ehlers-Danlos syndrome wait over a decade for an appropriate diagnosis after presentation with symptoms. And if you combine that with individuals with autonomic nervous system disorders, this results in a very significant delay in diagnosis and opportunities for treatment. Therefore, at the University of Utah, we formed the Ehlers-Danlos Syndrome's Multidisciplinary Clinic to help improve diagnostic rates and care for these patients. The team that we assembled included Dr. Douglas Ball, a medical geneticist, myself, Dr. Michael Green, a physiatrist, Dr. Stephen Trapp, a clinical psychologist, and Brad Jensen, a very talented physical therapist. Over the last 18 months, we saw approximately 65 patients. The vast majority were referred for evaluation of hypermobile Ehlers-Danlos syndrome. We were able to confirm this diagnosis in nearly half of the individuals. However, importantly, we actually made some other diagnoses, including 2 individuals were diagnosed with the arthrochalasia form of Ehlers-Danlos syndrome, which is an incredibly rare form with only 30 individuals identified worldwide. What our data shows is that this likely is not as rare as people think, but it's underdiagnosed and therefore understudied. The other thing that we did was we looked at the true phenotype of these individuals, and we found in the vast majority their diagnosis of a genetic connective tissue disorder or other disorder did not fully explain their clinical phenotype, and therefore they warranted further evaluation. You can see on the right-hand side of the slide some of the concerning features that these patients were presenting with, and therefore requiring much more in-depth evaluation. However, nationally, there has been a trend to dismiss patients with suspected or diagnosed Ehlers-Danlos syndrome due to the thoughts that there are very little that we can do about this disease process. This is patently false. There is a significant amount of clinical interventions that can be done to improve the quality of life. Furthermore, there's much more research to be done in this domain that actually would improve our understanding of the disease process and the comorbid disease burden that these patients experience. This last little piece of data that I'm going to show you is that the vast majority of patients also had symptoms that were suggestive of a dysautonomia. Of the individuals who underwent formalized autonomic testing, 85% were diagnosed with a dysautonomia. What's concerning is that when we didn't order the testing ourselves, 19 individuals did not undergo testing. And this further suggests that these patients are not being appropriately evaluated or undergoing appropriate diagnostic modalities, even when suggested by an expert care team. So in closing, we know that gender bias exists in medical care, and it's actually quite common. Our concern is that there are higher levels of gender bias in medical care for rare and complex female predominant disorders, as shown with the data from POTS. We also know that delays in diagnosis result in delays in treatment and progression of phenotypic severity, which greatly impacts patients' quality of life. We also are seeing a signal that misdiagnosis may result in long-term psychological injury to these patients because oftentimes they are blamed for their disease. In closing, I would like to thank, as always, my patients for their generosity and my collaborators within the EDS clinic and Dr. James Hemp for data analysis. And thank you for your time.